So this is a case of a 55-year-old postmenopausal African-American woman. She's the mother of two teenage children, and she palpated a lump in her right breast approximately 2 years ago. And at that time, she had imaging that suggested the presence of multifocal disease, with the largest tumor by imaging about 2.5 centimeters. The imaging also revealed the presence of suspicious axillary lymph nodes, and both the breast mass and the lymph nodes were biopsied and proven to represent invasive ductal cancer, ER/PR negative, and HER2 negative as well, so a triple negative tumor. She was BRCA tested, and due to the fact that she had a triple negative tumor and given her age, and her BRCA testing did not reveal the presence of a gene mutation. Distant imaging or distant disease was not confirmed on imaging, and therefore she was treated with curative intent and actually went through a mastectomy up front and a lymph node dissection, and the largest tumor was 2.5 centimeters, 2 out of 20 positive axillary lymph nodes. And at that point she was treated with adjuvant chemotherapy with doxorubicin, cyclophosphamide, followed by taxane, and completed that therapy, tolerated it reasonably well, but did have some issues with nausea, vomiting, diarrhea, so had a bit of a tough time. Then on routine follow-up at 18 months, she presented with a cough and abdominal pain, and this led to imaging, which unfortunately confirmed the presence of multiple lesions in the lung and liver, which were again biopsy proven and found to represent triple negative metastatic breast cancer. In the first-line setting, she was offered combination chemotherapy with gemcitabine and carboplatin, and follow-up imaging at 3 months did show stabilization of disease. 7 months after starting gemcitabine and carboplatin, she did have progression on imaging with a lung lesion increasing in size to about 3.5 centimeters. And at this point, a discussion occurred, and it was decided to treat the patient with capecitabine. And she responded to capecitabine for several months, but then ultimately developed progressive disease and was treated with eribulin. So my initial impressions of this case include the fact that we're worried about this patient. She has an aggressive tumor. She has a grade 3 tumor. It's triple negative, and she has lymph node involvement, so all signs of general poor prognosis. We know that triple negative breast cancer accounts for approximately 15 to 20% of all breast cancers, and disproportionately affects younger women, women of African American ancestry, and women who have the BRCA gene mutation. Due to the worse prognosis of this subtype of breast cancer and our increasing understanding of the heterogeneous nature of the disease, there has been a general trend or a shift in the treatment of these tumors with more neoadjuvant therapy. We know that neoadjuvant treatment results in a window of opportunity to assess response to treatment, and the achievement of a pathologic complete response is a surrogate for event-free survival. We know that patients that don't respond well and have residual disease are at higher risk of recurrence, and are currently the subject of many clinical trials looking to give additional therapy, such as genomically directed therapy, checkpoint inhibitors, vaccine studies, and now we also have data for the use of capecitabine in the post-neoadjuvant setting. So in my practice, I think this patient would have gotten neoadjuvant therapy for the reasons I discussed.